Okay, so what we're going to do today is we're going to continue on from yesterday's story. Yesterday's story was primarily about the structure of the lung and the conducting and respiratory zones. What we didn't talk about yesterday is how we managed to get air down into those conducting and respiratory zones. So much of today's discussion is going to have to do with this idea of ventilation. And ventilation is just a fancy word for me to say breathing in and breathing out. To understand how ventilation works, we have to spend some time talking about the structure of the thoracic cavity. And as we work our way through the structure of the thoracic cavity, what we'll do is we'll draw the lung as we had it yesterday. But now we're going to add a new component. We're going to surround the lung with a structure known as the pleural sac. The pleural sac is going to be composed of two layers of mesothelial cells. The mesothelium surrounding the lung is going to look an awful lot like the mesothelium surrounding the heart, where we had a pericardial sac. But now we're going to have a pleural sac. And we're going to see this, much of what we talked about in the heart is going to be true here as well. We're going to fill the space between those two layers of mesothelial cells, one the visceral pleura and the other the parietal pleura. We're going to fill that space with fluid, and that fluid is going to be somewhat slippery. So it's going to allow for the lung and the body wall to slip past one another easily every time we take a breath. This fluid-filled space of the this fluid-filled space called the interpleural space, which is between the visceral and parietal pleura, always has a negative pressure. That negative pressure largely comes from the idea that the lung itself is elastic. And it's plastered, it's held by mechanical connections to the body wall. And because it's trying to contract in, we in the end up with a negative pressure. This negative pressure will be important later on when we begin talking about what happens when we get a pneumothorax. We poke a hole in the body wall, and by poking a hole in the body wall, the pressure inside the pleural space comes to equilibrium with the outside world. That is what happens with a collapsed lung, and we'll talk about how that happens. Now, it's true that while you're exercising hard, you'll not only use your diaphragm, but you'll use your intercostal muscles to breathe in. But to make this thing straightforward, we want to talk about breathing when you're sitting there quietly. So as you sit here quietly and listen to this lecture, you're using your diaphragm to bring air into the lung. And what we're going to see is the diaphragm is this wall of muscle that separates the thoracic cavity from the abdominal cavity. The diaphragm is unique to mammals. Only mammals evolved a diaphragm. But in the process of evolving a diaphragm, that muscle originated as body wall muscle. And that body wall muscle is voluntary muscle. So what we'll see here is that the diaphragm is innervated by lower motor neurons. And the diaphragm is skeletal muscle innervated by lower motor neurons, just as we talked about in the nervous system, we talked about in muscle. Same story. In this particular case, the lower motor neurons will have their neuronal cell bodies in the ventral horn of the spinal cord between C2 and C5. Those lower motor neurons will send processes out into the periphery. They will form a structure known as the phrenic nerve. The right side of the spinal cord will generate one phrenic nerve, the left side will generate the other phrenic nerve. And because we're bilaterally symmetrical, we'll see that the left and right phrenic nerve, respectively, innervate the right and left halves of the diaphragm. Now, what happens here is that when we activate those lower motor neurons, when we turn on those lower motor neurons, fire action potentials in the lower motor neurons, and they arrive at that neuromuscular synapse. They release acetylcholine, go through the same story we've seen so many times before. That causes contraction of the diaphragm. Now, normally, the diaphragm is domed. It sticks up into the thoracic cavity. And then when we activate the diaphragm and cause it to contract, it flattens. Now, that flattening, the going from a domed shape to a flattened shape, that now changes the volume of the thoracic cavity. So fundamentally, the contraction of the diaphragm increases the volume of the thoracic cavity simply by the contraction. That then brings us around to a little bit of physical chemistry. Sometime in the late 1600s, there was a guy named Boyle. And Boyle sorted out something known as Boyles Law. And Boyle's Law simply says that P1V1 is equal to P2V2. This is talking about the pressure and volume in one container versus the pressure and volume in another container. For us, these containers are pretty simple. This left-hand side of the equation, the pressure and volume, is the atmosphere. It's the ocean of air around us, an enormous volume at a fixed pressure. P2V2 is the pressure and volume within the pulmonary space, inside the lung. So now let's think about the connection of the diaphragm to this equation. When the diaphragm contracts, when it shortens, and it increases the volume of the thoracic cavity, this number goes up. This number is atmospheric, so it doesn't change. So if this number goes up, and this number is fixed, what has to happen to P2? It's got to go down. Well, if P2, so now under these circumstances, P2 is less than P1. So if P1 is greater than P2, we have a pressure differential. Given a pressure differential, we'll have flow. Because remember, after all, delta P, this pressure differential, is equal to the resistance times the flow. This is Ohm's law. And so now air is going to flow through that conducting zone down into the respiratory zone. And that flow of air is a result of this equation and the role of the diaphragm. And that's all well and good. That tells us how we get air into the lung, but it doesn't tell us very much about how we get air out. And we know that every day, 12 times a minute pretty much, we breathe in and we breathe out. Breathing in is an active phenomenon. We contract the diaphragm and bring air in through this story of P1V1, P2V2. But the breathing out is simply a passive elastic response. So where it's true that we have provided amount of energy when we contract the diaphragm, the other side of that is the energy that we're going to use to expel the air is contained within the elastic nature of the lung itself. We can think about this in the same way we've thought about muscle over and over again. And that is, remember when we talked about skeletal muscle, we said when we contract it, we shorten the sarcomeres. But then we had to do something active to reset the sarcomere length. And we'd use the antagonistic muscle to reset that sarcomere length. And that's the way antagonistic skeletal muscle works. We said the same story was true in the heart. In the heart, after the myocardial contraction, to reset the sarcomere length, we had to allow blood to come into the ventricles and re-stretch that sarcomere length. It was the refilling by the low pressure return that re-stretched that sarcomere length. Here what we're going to find is that we're going to reset the sarcomere length in the diaphragm by the elastic characteristics of the lung. The elastic characteristics of the lung come mainly from three sources. One is there's going to be this molecule we've talked about before in the extracellular protein matrix, elastin. Remember, these are the spring-like molecules. These are spring-like molecules in the dermis, which allowed our skin to come back to its original shape. So we'll see then that when we expand the alveolus and air comes in, we'll use, to some extent, the elastin molecules in the extracellular matrix around the alveolus to bring it back to its original position. There's another less obvious, though, force that's acting here, and this is the force of surface tension. One of the ideas here is that once we get down into the alveolus is no more than about 0.2 of a millimeter across, 200 micrometers. At those dimensions, when you're down to 100, 200 micrometers, these dimensions are so small that the apical surfaces of the epithelial cells in the alveolus can interact with one another. In other words, there's a water layer over all of those epithelial cells. And as those epithelial cell surfaces get close together, they stick to one another by surface tension. So the very same surface tension we talked about on the first day of discussions in here, that surface tension which results from the hydrogen bonding between the partially negative charged oxygen and the partially charged positive ends on water, that surface tension now is going to draw these surfaces of the alveolus together. And in fact, these forces are so strong that normally under normal circumstances, we have a separate set of cells called type 2 pneumocytes. And the type 2 pneumocytes are generating a detergent, a surfactant. And what the surfactant is it's mostly phosphatidylcholine. You remember this is an amphipathic molecule we found in phospholipid bilayers. The phosphatidylcholine will actually insert itself, intercalate itself between the water molecules and effectively form a kind of insulation between the dipole moments of the water, separating them. So that will reduce the surface tension. We'll see that as we expand the alveolus and we decrease the number of these phosphatidylcholine molecules in that volume of the water, the surface tension gets higher and higher until when we stop bringing air in through the contraction of diaphragm, there's a tendency to snap this thing back to its original position because of the surface tension. So the two main forces here to bring the shape of the alveolus back to its original shape and position are the elastin and the surface tension. The last one is the negative pressure inside the intrapleural sac. And there's always a negative pressure in there. Under normal circumstances, the pressure inside in the pleural space, in the intrapleural sac, is always less than atmospheric pressure. And I'll illustrate this by the horror of a wound that opens up the pleural sac to the outside world. Could be an automobile accident, could be a gunshot, it could be a knife wound. But if you open up that intrapleural sac such that the air comes rushing in and equalizes the pressure from the outside world into that intrapleural sac, the elastic nature of the lung will have it collapse on itself. And we'll talk about how we treat that and how we can understand the treatment in terms of allowing for that vacuum, if you will, inside the intrapleural sac. And we'll walk our way through it. But let's start here with the idea of ventilation, which is just a fancy word for breathing in and breathing out. Ventilation and the structure of the thoracic cavity. We'll start here with the same story we had yesterday, where there's the larynx, trachea. The trachea then branches into the two bronchi for, in this case, the left and the right lungs. And then these structures then branch and branch and branch. And we talked yesterday about the tertiary and the secondary and tertiary and quaternary branches. But we get this tremendous amount of branching of the conducting zone. And this happens on both sides. And then remember, at the end of this conducting zone is going to be the respiratory zone, and I'll show that in blue. So this is an alveolus. And then surrounding this structure, and let me put in blue here, this is meant to be the outer limits of the lung. And we have on the left side and on the right side the outer limits of the lung. Let me make this a little smaller here. Now, attached to the outer wall of the lung is a continuous cell layer. So I'll draw these in an orange. We have this continuous cell layer attached to the body wall. It's attached to the body wall by an underlying basal lamina. So there are these extracellular proteins lashing those cells to the wall of the lung. And if we follow this around, the entire lung is covered by this layer of mesothelial cells. These mesothelial cells form a continuous layer on the wall of the lung. But then we see that this continuous layer folds back on itself to effectively form two layers. Both of these layers are oriented in the sense that there's a basilar surface and there's an apical surface. So the basilar surface of this layer is attached to the lung, but the basilar surface of this outer layer is attached to the body wall. So in black here, this is intended to represent the body wall. This gives rise to a little more nomenclature, where this layer of mesothelial cells attached to the body wall is said to be the parietal pleura. And this layer of mesothelial cells attached to the lung itself is called the visceral pleura. You'll remember that we had the same story. We talked about the heart. We talked about the pericardial sac. And we said in the pericardial sac, there was a layer of mesothelial cells attached to the wall of the heart, and there was another layer of mesothelial cells attached to the body wall. The basilar surfaces were out here, and the apical surfaces faced one another. And then in the pericardial sac, those apical surfaces secreted a fluid, such that now there was a fluid here inside the sac. And that's true here as well. This region called the intrapleural space. The intrapleural space is formed by these two layers of mesothelium, one attached to the body wall out here, the visceral pleura, and one attached to the lung here, the visceral pleura, and the other attached to the body wall, the parietal pleura. Then the apical surfaces facing one another have now secreted a fluid. And just in the heart, in the pericardial sac, where with each beat of the heart, the wall of the heart could slip by the body wall, here, each time we take a breath, and we bring air into the lung to expand the lung. Each time we do that, and then we expel the air when we exhale, then the two surfaces can slide along one another. And they slide along one another fairly friction-free because of the fluid inside the pericardial sac. If you know someone who's had pleurisy, that's where these two layers get inflamed. Sometimes they actually swell and fill with fluid, but sometimes there isn't enough fluid. And then there's basically friction between the parietal and visceral pleura. And apparently it's really, really painful because these mesothelial cells are, in fact, innervated. And each time you slip by one or the other, it causes a lot of pain. But what I want to think about, though, is the idea that the two surfaces are attached to the body wall through the parietal pleura and to the wall of the lung through the visceral pleura, leaving this space in between. And I'll say this now, we'll come back to it, is that this space, the so-called interpleural space, is always at negative pressure. With respect to atmosphere. Well, the next character in this story is located down here. What I'm trying to show with this is this red structure is meant to be the diaphragm. The diaphragm is skeletal muscle. To think about its innervation, I'm going to come over here and draw the spinal cord. This is the sort of standard view of the spinal cord, where this is going to be the left. I have to turn things around on you here. This is going to be left. This is going to be right. To maintain this orientation with the left side of the lung, left lung and right lung. Then what I want to do is I want to follow the path of the lower motor neurons. Now remember, whenever you see a cross-section of the spinal cord like this, and we talk about the ventral horn, this is going to be the home of lower motor neurons. So we're going to find neuronal cell bodies in here of lower motor neurons. Now, the lower motor neurons from the left-hand side will now come out and form a structure known as the phrenic nerve. And we are bilaterally symmetrical, so we have another set here on the right side. These two come out and form the right phrenic nerve. Now, the motor neurons here, whose cell bodies are in the ventral horn, these are located between C2 and I think it's about C5 of the cervical spinal cord. That's a detail. But if you know that these are lower motor neurons, then you recognize that this is going to follow the same rules. These are going to follow the same rules of innervating the right hemi-diaphragm. And from the left side, these lower motor neurons are going to innervate the left hemi-diaphragm. Now, it's true that there are going to be upper motor neurons here. It's true that these upper motor neurons are not going to be in the precentral gyrus. They're actually going to be in the brainstem. And those upper motor neurons are going to be driven by a circuit. It's going to have a repeating pattern to it so that you breathe in and out in a regular rhythmic fashion. But this is a voluntary system, and we know this because we can hold our breath, at least for a while. And we hold our breath by stopping the action potential propagation through these lower motor neurons. But under most normal circumstances, what we do is we allow the circuit to activate the lower motor neurons. These are simple lower motor neurons. These fire action potentials. When the action potentials arrive at the output region, they release the neurotransmitter acetylcholine. This is skeletal muscle. So that acetylcholine is going to bind to the acetylcholine receptors, the ligand-gated ionotropic channels. That will open those nicotinic acetylcholine receptors, generate an EPSP, cause action potentials in the muscle fibers, release of calcium internal stores, the whole story. That's now going to cause this muscle to contract. This is just skeletal muscle. It obeys all those rules. So when that muscle contracts, it goes from this position of being domed, and when it contracts, when it shortens, it flattens. So it goes from this domed position, so a more or less flattened position. So this is meant to be activated / contracted diaphragm. Now again, remember that this is a closed system, that this diaphragm muscle walls off the thoracic cavity from the abdominal cavity. So we have now two separate spaces, the thoracic space and the abdominal space. When this muscle contracts and the sarcomeres shorten, when the sarcomeres shorten here through the same mechanisms we've talked about over and over again, When these sarcomeres shorten and this flattens, what's it going to do to the volume inside the two lungs? If this comes down, what's going to happen to the volume in here? It'll increase the volume. So we can now spell this out. We can say contraction of the diaphragm increases the volume of the thoracic cavity. So, yes?
I just have a question. So when it comes to the nerves, since they innervate on the right and the left, if there's paralysis, does that mean that the diaphragm only works half as well? Or?
So the question here is, if we have some form of a stroke or something happens and we wipe out this side. That's right. If we wipe out the right side, the ventral horn in here, if there's some sort of damage, or if in fact there's a Brown-Séquard incident where you cut the spinal cord in the cervical region halfway, you will lose innervation to this side of the diaphragm. But the other side of the diaphragm will still work. It won't work as efficiently. It won't be quite as good, but it will still shorten. It will still increase the volume inside the thoracic cavity. And so by increasing the volume, you're now going to generate a pressure differential. Yes?
Is that typically why you see people with that kind of damage? They have huge intercostals. They're using their intercostals to...
So the question, yes. Okay. And I have glazed right over that. Because while it's true that when you're sitting here quietly, you use your diaphragm, when you start exercising hard, you'll start now trying to increase the volume of your thoracic cavity by contracting your intercostal muscles. It's called called a pump handle action. So you basically swing the rib cage up by the contraction, and that increases the volume. So that, and you're right, if there's some problem here with the phrenic nerve, then you can compensate for that to some extent by using the intercostal muscles. And if you've known someone who's pregnant, you know toward the end of the pregnancy, breathing gets to be really difficult because what's happening is the baby's begun to encroach on the contraction of the diaphragm. And at the last few weeks of pregnancy, you'll find that women have to breathe largely with their intercostals, and it's a real struggle. So I'm told. And so now what we want to think about is the mechanics of this. And this comes back to something called Boyles Law, where P1V1 is equal to P2V2. P1V1 is atmosphere. This is atmospheric pressure. This is the volume of the entire ocean of air around us. That doesn't change. That's fixed. P2V2 is the volume of the thoracic cavity. And P2 is the pressure in the pulmonary space. So now this is just simply working with the algebra. This number doesn't change. We've said that we have increased the volume, that when we contracted the diaphragm, that increases the overall volume of the thoracic cavity. So that means this number goes up. If this number goes up and this number is unchanged, what does this number have to do? It's got to go down. So since this number is fixed, now P1 is greater than P2. We now have a pressure differential where P1 is greater than P2. We have a delta P. Anytime you see a pressure differential, you can think the resistance times the flow being Ohm's law. That's simply a long-winded way of saying that when we contract the diaphragm and we increase the volume, we now generate a slight vacuum in here, and air comes rushing in. This is the point often where I'll talk about a bellows, and then I get a blank look from most people in the audience. How many of you know what a bellows is? Yeah, it's a small number. Okay, so what a bellows is something, when you want to make a fire, you basically take two handles and you expand the bellows. So that if you, let me put it in the backboard. So this is the bellows, and it comes out like this. And then back here, it's like another two handles. And up here usually is a valve. So what you do is you pull these two handles apart. What's that going to do to the volume in here? Increase the volume. So what's it going to do to the pressure in here? It's going to go down. So the atmospheric pressure allows the air to come in. And then where it breaks down is then we'll actually mechanically push this to force the air out. Now, these were commonly used to fuel air into a fire at a blacksmith shop. And usually when the light comes on here is when I talk about when Ned went to the blacksmith looking for Robert Baratheon's son. And they're in the blacksmith shop, and in the background, there's this bellows working. And it's Genji is the character. And he's there working the bellows. And what he's doing is he's expanding the bellows and contracting the bellows. Every time he expands it, he uses air pressure to bring the air in, just like we do when we contract the diaphragm. Now, unlike the bellows at the forge, we don't use a mechanical force to contract the bellows. What we're going to use now is the elastic recoil in the system. So the next step is to talk about elastic recoil. So any questions up to here? So yes?
So is this just like the direction of flow or the magnitude of flow?
So the question here is, what's the difference between the directional flow and the magnitude of the flow? So the direction of the flow is simply we increase the volume, decrease the pressure, and the air comes in. So that's the direction. The magnitude of the flow is going to be how much you constrict the diaphragm. So you can take a deeper breath or a shallower breath. The more you constrict the diaphragm or contract the diaphragm, that will mean that you'll get a greater volume coming in, and probably also increase the rate, simply because you've made a greater pressure differential in a shorter period of time. And I'm sure there's calculus to describe that, and the air is going to come in. Anything else? Yes?
When we're holding our breath, are we making more neurons onto the diaphragm to activate the muscle?
So when we're holding our breath, what we have done is we have breathed in, and we're now continually activating that diaphragm to keep it in that contracted position. Because what's going to happen when we stop delivering action potentials here, then we're no longer signaling the sarcomeres to shorten. So the next step here is to try to figure out how those sarcomeres are going to return to their original length. And again, as we said before, skeletal muscle, it's easy to see, antagonistic muscles. In heart, fairly easy to see because it's the low pressure returning these Z lines to their original position. Here it's a little more difficult to understand, but it turns out that what's going to return these Z lines to their original position after they're in the contracted state, what's going to pull them back out again, is going to be the elastic recoil, the elastic characteristic of the lung itself. And that's where we're headed. So let's go to the upper panel. And I want to spell this out and then see if we can describe it mechanically. So we'll start here with sources of energy for elastic recoil. Well, the first thing I want to do here is draw one of my overly simplified views of an alveolus, and I'll try to make it a little more rounded this time. So this is meant to be an alveolus. Inside is meant to be air. And this is the blue thing we have on the upper panel, and if we would get inside this air sac, we could walk along the epithelium all the way to the outside world, a continuous layer of epithelial cells. The rules for that epithelium are, as we described yesterday. The epithelium sits on a basal lamina. And then there's this very, very narrow gap between these flattened epithelial cells here and these flattened endothelial cells. So these green structures are meant to be the endothelial cells of the pulmonary capillary. Outside here, there's going to be this, between the epithelial cells and the endothelial cells, there will be this very thin layer of basal lamina. But among those proteins, among the extracellular proteins, is going to be an old friend. There's this extracellular protein called elastin. So now you can imagine in this confined space, when we breathe in, this confined space is going to expand. But it's surrounded by rubber bands, if you will, in the form of elastin. So when we expand it, there's also now, when we stop contraction of the diaphragm, we stop bringing air in, then the passive response is for these elastic rubber bands to spring back to their original position. Because when we expanded this and made it bigger, we stretched out these elastin molecules. But now, when we stop contracting the diaphragm, we've stored energy in the extension of the elastin, and some of that energy now is going to help snap this alveolus back to its original size and position. The other important characteristic here that's a little harder to see, I think, intuitively, is that the overall diameter of one of these air sacs is in the neighborhood of about 0.2 millimeters, about 200 micrometers. So they're pretty small. And one of the characteristics we're going to see a little later when we talk about gas exchange is the apical surface of these epithelial cells is covered by a thin layer of water. So this is a water layer. These spaces are so small that we now begin to have effects of surface tension. Any of you who have ever fiddled with glass plates and water know that if you get a thin layer of water between two glass plates and you try to pull them apart again, they're not pulling apart. You can slide them, but you can't pull them apart. And the reason for that is that these water layers will have surface tension, which is generated by hydrogen bonding. You may remember from the first discussions in here that when we looked at the water molecules, that they would have a partial negative end and a partial positive end. And the electromagnetic fields, the electrostatic interaction between water molecules then would allow for this partially charged positive end to interact with the partially charged negative end on the water. And we said that this was hydrogen bonding. This can be a quite strong force down at these small volumes. And what we normally do is we have a set of cells in here, in orange. These are called type 2 pneumocytes. The blue ones here are called type 1. And these are the sites of gas exchange. These orange type 2 pneumocytes have a different role. What they do is they secrete phosphatidylcholine. We've run into phosphatidylcholine before. This is an important character in the phospholipid bilayer, and its claim to fame is it's amphipathic. And we abbreviated that with a kind of shorthand where we had the charged head and uncharged tail. What happens with these molecules, because they can live in both worlds, is they can have these charged heads interacting with usually the negative end on water, but then their tails insert between neighboring water molecules. Effectively, you can think about this as providing an insulating layer between the dipole moments on adjacent water molecules, so that now these dipole moments don't interact with one another so strongly. So the effect of these amphipathic molecules, these so-called surfactants, is to reduce surface tension. To give you some sense of how important this is, just before birth, one of the things that happens is that these type 2 pneumocytes in the lungs of the baby that's about to be born are turned on. And they're turned on so that they can generate phosphatidylcholine to reduce the surface tension. One of the real risks for premature birth is that these type 2 pneumocytes have not been activated. So in these babies, you find there's no phosphatidylcholine being produced. So in those cases, these alveolar spaces are very hard to open because the alveolar spaces are stuck together by the surface tension. And these babies labor terribly to try to breathe. And there's been a lot of work trying to figure out in premature births, how do you manage to get these phosphatidylcholine molecules into the surface water to break up that surface tension. But in adults, once you get this balance right, this surface tension and the phosphatidylcholine become important. So let's think about this for a minute. We have this surface tension in the fluid inside the alveolar sac. We breathe in, and it gets bigger. As it gets bigger, these water molecules begin to separate from one another, but more importantly, because we have a finite number of these phosphatidylcholine molecules, we now effectively reduce the number of them in this region. So the concentration effectively goes down. The concentration of surfactant goes down. So as you expand the alveolar space, as this gets bigger, the concentration, because we have a finite number of phosphatidylcholine molecules in here, the effect on the surface tension gets less and less. So as you expand it, there's more and more of a tension to bring this thing back to its original shape. So then we breathe out. We stop the contraction of the diaphragm. We're no longer providing the differential in pressure to bring air in. So now the forces, some from the elastic recoil, and some from the surface tension of the fluid in the alveolar space, begin now to bring back these structures to their original position, and thereby bring the volume of the whole lung back to its original volume. So we now go back to the original state of P2V2. And we use this elastic recoil to force the air out of the lung. It's all passive. And in the process of using the elastic recoil, we reset the sarcomere lengths. So any questions to there? There's a third force involved here in the so-called passive recoil. And that third force is the negative pressure that's here in the interpleural space. Remember we said early on, because of the elastic nature of the lung, it wants to collapse on itself, but it's being held against the body wall by these regions of basal lamina connected to the mesothelium. This thing is held against the body wall. That always leaves inside here, in this very narrow gap between the visceral and parietal pleura, in this intrapleural space, a negative pressure. It's always more negative with respect to the lung. Now, let's imagine that we break this thing open. Could be a knife wound, it could be a car accident. Some way or another, we break open this intrapleural space to the outside world. It was at negative pressure. What's the air going to do? It's going to come in. That's going to collapse the lung. Because of the elastic nature of the lung, it's going to collapse on itself. So now, the other problem, though, is that the pressure inside the interpleural space is the same as the outside world. So even when you contract the diaphragm and try to increase the volume in here, if you increase the volume inside the lung, the lowest resistance is for the air coming through this hole rather than in through the trachea. So the lung is collapsed, and now you can't bring air down into the alveolar space. EMTs are trained to look for this because you need to fix this right now. And what will happen is an EMT is trained that they see a thoracic wound, patch up that wound, get it covered over, seal it as best you can, and if possible, get another tube into this interpleural space and draw out the air. And if you do that, then you can bring this back to negative pressure and allow the lung to expand. Yes?
You can use a three-sided occlusion dressing, so when they breathe it, you know what I mean, the air comes out and then it sucks down when they go to breathe in.
So that's what they do. They use three-sided. So that when they breathe in,
the plastic sucks to the side when they breathe in, so the air doesn't come in, or vice versa, when they breathe out, it sucks to the side when they
right.
breathe in. Yeah, and so it pushes the air out.
Right. So you're actually using the inspiration to push the air out from the interpleural space.
Right.
That's pretty clever. Yeah. And this becomes really important in any thoracic wound. Now I won't tell a story. So what I want to finish with here is this idea of elastic recoil versus compliance. These are simply the inverse of one another, and I won't get into the mathematics. But you can imagine a case where we have damaged these elastin fibers. This often happens in chronic smokers, or people who are exposed in their daily lives to atmospheric stuff that damages the elastin filaments. You can also then imagine a situation where once you've damaged the extracellular protein matrix here, that these alveolar spaces now get bigger. So two things are now happening here. We've damaged the elastin, so it's no longer springy. And the other is the alveolar spaces are so big that we've reduced the effective surface tension. In that case, where we have damaged the elastin and increased the diameter of the alveolar space, compliance goes up. Basically, just isn't as much springiness in the system. So in those individuals where they've damaged the elastin and increased the size of the alveolar space, it's really easy to breathe in. They can drop the diaphragm, generate a pressure difference, air comes in just fine. But the problem is they have damaged the elastic recoil. So these individuals have a very hard time breathing out. If you've ever watched someone with emphysema breathing, you can recognize they breathe in just fine. But then they purse their lips and work very hard to try to get the air back out again because they've damaged the elastic recoil. The other side of that story is there are other diseases where we build up the extracellular proteins. We don't understand why this happens, but there are these so-called fibrotic lung diseases. And in the fibrotic lung diseases, we building up the extracellular matrix. And in that case, the lungs and down around the alveolar spaces get much more difficult to expand because of all the extracellular protein. So these people have just fine elastic recoil, but their compliance is so bad they can't breathe in. So again, breathing in is an active diaphragmatic story. Breathing out is a passive elastic story from the elastic recoil. And we'll leave it there, and we'll come back to gas exchange tomorrow.